So welcome everybody to this session in which we will be talking about the longer term impacts of the COVID-19 pandemic. Obviously, we are the post-COVID summit, but in many parts of the world, in fact, probably everywhere in the world, we are probably not through the pandemic yet, but there is already a lot of learning for us, and we will be focusing a lot on mental health. We'll be focusing on the societal and equality implications of the pandemic. The vaccines are here. We have, in many countries, especially around Europe, we've seen lockdowns finishing, but also in other parts of North America as well. So we might think that the impact of COVID-19 is coming to an end. But this is clearly wrong. We know that this is clearly wrong. We should probably look at the pandemic more as a COVID decade and not as a COVID pandemic. There are social, economic, and cultural effects that will cast a long shadow into the future, and potentially even longer than a decade. We know from previous pandemics that they can be a force for change and for long-term impact. So the sooner we begin to understand, the better placed we will be to address those impacts. There are, of course, many impacts which flowed from lockdowns, including not being able to see friends and family, not being able to travel, take part in some of our hobbies, and this should ease quickly after lockdowns. But there are deeper impacts on our health, on our well-being, on our communities, the cohesion of our societies, employment, and more broadly, the economy. And these will have profound effects on many nations for many years to come. So the pandemic has exacerbated existing inequalities. It has also created new ones, and it has exposed many critical societal needs and strengths. And these are emerging differently across different places, across different time frames for individuals, for communities, regions, nations, and the world as a whole. So we will be talking about those effects in our session today. And we have a set of excellent speakers to help us navigate this difficult reality and this difficult world at the moment. I will start with Professor Elke van Hoof. She is a professor at the Free University in Brussels and expert in the Superior Health Council of Belgium in the European Parliament. And Elke will take us through, will give us the big picture, I think, on the pandemic and mental health. Elke, over to you.
Thank you. Thank you for the kind introduction as well. I'm gonna start sharing my screen. Can you let me know if that works as foreseen? Let me shift my screen so you can see everything in full mode. Yeah. Does it work? Everybody sees?
Yes, that works. That works perfectly. Yes.
So as said in the introduction, I'm gonna try to give a huge overview of what has happened so far in this probably pre-post COVID era, and talk about some challenges and future perspective from all the work that we've been doing in Brussels in the Superior Health Council. Of course, let me first share some insights as COVID, for one, was extremely disruptive. If you look at the velocity by which COVID took over the globe, but also the other characteristics, there was a huge information overload, also, of course, due to the fact that it was work in progress. We had really to get all that information while we had to adapt to the virus. And adapt also our behavior to the virus. So there was an information overload next to that huge velocity, and that created a tremendous ambiguity that really placed a huge burden on our resilience. And then, of course, last but not least, the huge uncertainty also even today, as we are progressing slowly but surely, step by step out of lockdown periods, there is still an uncertainty of what lies ahead. And that is already one first insight, that we already before the pandemic, one of the predictors of mental distress was intolerance for uncertainty. And of course, COVID only increased the influence of intolerance for uncertainty, as it is now still one of the major predictors of distress in people. From all the data that we've been gathering, also from the Belgian data repository, I think one is a positive effect is that now today it has become more common to talk about mental health. Are we there yet? I don't think so, because in terms of structural initiatives and structural funding, we are still hugely underfunded. But what is fine is that it today is or appears to be already okay not to be okay. And I think that's a major start, that we already can normalize the fact that through our life that we can face mental health issues. And if this reduces the barriers to speak up, I think we already achieved a lot. Alongside that, what we also have seen, which is also very positive, is the fact that there are a lot of initiatives that have been created. One of those initiatives I launched myself, everyoneok.be, which is a low intense therapy and standalone intervention. Because Belgium went into lockdown, we wanted to have something that we could continue psychosocial counseling. And we were able to do not only give them low intense therapy in a standalone version, but also to gather data. And I think there also, with regards to mental health, it was very disruptive, as there were tremendous amount of initiatives, not only concerning e-health, but also outside, where we included non-psychologically professionals to reach out to people and to make sure that we could still connect with them and discuss with them. And I think that's also a major advantage. Now, one of the big insights is the influence of the context, where psychology always before the pandemic kind of like progressed fast over context influences. I think this pandemic has learned us that we cannot ignore context, and that not only individual factors, not only societal factors, but also the influence of the context and the velocity in which it can shift places also a huge challenge. And I'm going to share on my slide here some of the data, evolutionary trend data that we've been gathering the past 2 years. And there you can see actually that this stress is increasing the stricter the measures were. And while we came, once we came into more lenient measures, you saw immediately resilience increasing again. And so the importance of those types of data is helping us to be much more proactive. Where the pandemic was disruptive and not giving us time to adapt and prepare, I think we need to be prepared for upcoming similar disruptive trends, of course. And this said, there I think we have a major challenge on our hands, because while I think every psychosocial professional already was convinced that the biopsychosocial model was widely accepted, we've all encountered the influence of the biomedical model, where it was only first up to the medical professionals and mental health, if indeed was already addressed from the beginning, was only when there was some 5 minutes to spare. Where we now know, and we've known it before the pandemic, but now we've seen the importance. If people have a burden on their mental health, it also has its influence on their compliance and adherence to measures. And so I think there is still a major challenge, is in the new unknown situations, you can really identify the true drivers of society. And I think the biopsychosocial model is not yet accepted the way it needs to be. Another major challenge, and that causes really, that places a huge burden on being prepared, is that we tend to need, for every new paradigm, every new problem, needs a new paradigm. And I think indeed in a huge number of countries, we've seen the fact that it was appeared to be new. Actually, people were not easily adapting, easily advising on mental health, as we thought that this was a new problem that we first had to analyze what we had and our hands. And there I think we need to do better in the future, because when mental health is concerned, COVID and the burden of COVID is not so unique and not so new. As we look at the numbers now being gathered across the globe, giving the same trends over and over again. We fastly reached a sense of sufficiency, where even with new data that is being published today, still remain the same key messages getting across. And so we need a much more stepped approach, but also in our responsiveness to these types of disruption, because in most countries what happens is that people who were already vulnerable or who had already a psychosocial or psychiatrist diagnosis, they are worse off because we've lost their continuity in their counseling, in their treatment. And so for them, we've created really a well-being rupture, a gap that we will need years to bridge again. And so the other thing is that we need to search for solutions together, and we need to dare to use paradigms of the past to start and to prepare better and faster while the pandemic was taking over the world. By which I mean we did one exercise where we used the disaster model created in the 80s. And after some research that gave us a fairly good idea of what could be expected, where you first had the honeymoon during the lockdown, and then people were willing to invest in a lot of initiatives voluntarily, but that causes a lot of exhaustion, and that exhaustion then leads into negative effects of having to invest too much too long, and then increasing anxiety and depression rates became fairly obvious. And once those rates were up, it was extremely difficult to manage them and to treat them, to even reduce them in the general population. So we need to dare to use already existing solutions and have a fail-forward, fast approach, even in our mental health systems. And I think that's a major challenge across the globe. We need also in our mental health systems to activate still existing resources to uphold the continuity of contact with our patients and to make sure that we have a good flow in those resources. For instance, it is my belief that when we look at the general population, people with only few vulnerabilities, because indeed we all have our vulnerabilities, but if we look at the general population, I think we've missed the opportunity of using infotainment more to really teach people how to manage their resilience and how to manage their distress better. I think also there we need to take action. And we need to dare to use other models as well. And I'm just including one here as an example coming from Change at Work, where we also could provide non-psychosocial professionals with some very tangible action plans to go out, step out and help each other. As this model, for instance, gives us a huge insight. It's fairly simple and a bit simplistic from a scientific perspective, of course, but it can be very tangible in daily routine and daily practice to really upscale the resources once a pandemic is really taking over our resilience fast. Now, some words to wrap up on how I perceive from all the science that we did, how we perceive the way forward. I think we need to improve the alignment between the mental health needs and the availability, but also the accessibility of mental health and mental health systems. What we've seen even until today is that there is still a huge delay time when once a person or a family or a team member at work says, well, guys, I'm not holding up any longer, or not for much longer, that the delay between speaking up and then getting help is way too long. I think there is also today an increase of unmet needs due to the fact that across the globe there is still a challenge with regard to triage, by which I mean who needs what, where and when. And even if we look at some superb systems like we have in the UK or already in Australia with Access Project, even there, rules to really allocate people's needs to a specific place in the stepped care approach, guidelines and regulations for that are still lacking. So today, if we could answer that question, this could be a way forward to really address unmet needs better. But also, we have a need for real-time referral systems. Also there, there is a huge delay in between the time when people dare to speak up and then get their counseling ready. So we need to use the digital systems much more and better, where we also, for mental health issues, as psychosocial professionals, are just one click away of our people in need. Another thing is, and it was already addressed in the introduction, is that of course there is a huge socioeconomic and sociocultural division, because a lot of our solutions are based on the weird individuals. I really love that term. It's actually to identify that all the research that is available right now, also on the COVID until today, is based on Western, well-educated, industrialized, rich and democratic individuals. And so we don't have very good solutions for those people that we leave behind. And we there also assume that we can reach them with our solutions that are tested on the weird group. But even today, we need to acknowledge that that's not going to happen. So we need also to be able to go out and think outside of the box, as we are magnifying underlying social inequalities today. As I already said, there is a huge gap today between people who already had some vulnerabilities before the pandemic, not even only due to psychosocial issues, and today they are worse off. And it will take us a lot of years to bring them up to speed with everybody else. And rather than just focusing on groups like young people, adult people, elderly people, we need to focus on factors. And we need to take into account that those factors that can increase vulnerability, but also be protecting people from mental health issues, or can be a risk factor, that those factors are cumulative and multiplicative. That means the more of those factors you have, the higher the risk, and the better you should have accessibility to mental health systems. Even today, across the globe, if you look at how countries perceive risk factors, we are still looking at age groups rather than the amount of factors a group can have. This could also be an answer to quantifying resources in different member states, as we can use these groups and then look at statistics within countries to really calculate and quantify the resources that we need to target these more specific groups. And you've seen the list that from the Belgian research, where of course we included a lot of international research, as we probably will hear of the colleagues today. You see already a first list. And of course, you all also see intolerance for uncertainty, as this has become an even more important aspect. So we need to kind of like get people enthusiastic to go out and structurally fund mental health progress. As I said, we are normalizing mental health issues. It's okay not to be okay, but then when you look at the funding we have today, also for the already taken initiatives, I'm just going to share one example. In Belgium, there is in Brussels a building that is now getting funded for 80 million euros to get renovated. And for the whole of Belgium to really uplift psychiatric wards, as we have an increase of needs, we are allocating just 5 million euros. And so I think we're just not there yet. Although I've seen progress, I really want to place out a call to action to really put mental health first as a top priority on the political agenda as well. I'm going to leave it here for my introduction and give the floor back to Antonis. Thank you.
Thanks so much, Elke. That was a really eloquent presentation, and thank you for putting to words a lot of the things that have actually been, I think, frustrations for many of us working in the field over the past couple of years. So thank you so much. We'll move on to now to Professor Frances Williams. She's Professor of Genomic Epidemiology and an honorary consultant rheumatologist at King's College London. Frances, I think, will go a little bit into more of the specifics of the COVID impact and present also some of the insights from a really important COVID symptom study. So over to you, Frances.
Thank you very much. Can you see my slides?
Yes, that works. Yeah.
So I've just got a very brief summary on some of the work that we're doing in King's College London. I work in the Department of Twin Research, where we set up in collaboration with Zoe, the Zoe Symptom Study app, which was produced before the end of March 2020 by my colleague Claire Steeves. We're also part of National Core Studies of Health and Wellbeing. So there are some data being shown from that as well. So what we have been attempting to do is use different types of population studies, all of which include community dwelling populations, to understand better the effects of COVID infection. So because we're examining community dwelling populations, only a small number of these participants are admitted to hospital. Of course, the folk that are admitted to hospital have serious illness and have necessarily long-term sequelae from that. But we are interested in focusing on the long-term effects of relatively mild illness that occurs in the community. So the Zoe app has recruited what we recognise is a non-representative volunteer population from across the UK, and also within the US and Sweden. So we have the ability to replicate our data across countries. And we've also worked with 9 national longitudinal studies, which were already in existence before the pandemic struck in 2020, so that we have pre-pandemic data on those cohorts. We've also used electronic health records available from the NHS for people who have a documented COVID-19 code. So what is long COVID? This obviously is work in progress and definitions are changing, but at the time this slide was made, long COVID were the signs and symptoms of the infection that continue after the acute infection, i.e. for more than 4 weeks. We were referring to ongoing symptomatic COVID-19 infection as lasting from 4 weeks up to 12 weeks. And then post-COVID syndrome was the name given to those symptoms and signs that continue for more than 12 weeks, which are not explained by an alternative diagnosis. You can see from the panel on the right that there is a very rapidly declining number of people who have these symptoms, and by 60, 80 or 100 days, we're really talking about relatively small proportion of the people affected. But of course, COVID is absolutely everywhere, and just a 1% prevalence means many millions of people will be affected with ongoing symptoms. So we examined over 4,000 COVID positive cases and asked them about their symptoms in the short, long and very long term. And you'll see from the panel on the right that the most frequent long-lasting symptoms were fatigue and shortness of breath. And I can attest to that, having just had my second dose of COVID last month. These are annoying symptoms that persist. And we're also doing some work to look at the different clusters of symptoms that are evident in the post-COVID setting. So the most predominant setting, symptom cluster, does comprise upper respiratory tract and shortness of breath. And then there's a second, more neurological cluster that is less prevalent but still very evident within the data around headaches and loss of smell and taste. So how common is long COVID? And this work was performed before we started vaccinating people. We looked at the people experienced significant impact on daily life 12 weeks after catching COVID-19. And you can see from these two pie charts that there is quite a difference in the prevalence by age, with only 1% of 20-year-olds having symptoms at 12 weeks, while 5% of the young and middle-aged people between 30 and 50 had ongoing symptoms. And that's reliable data from a wide variety of these cohort studies. And if you look longitudinally, it's still further out in age, you will find that the age relationship continues. One of the positive findings we've made is the study of vaccination and its influence on the risk of long COVID. And in a sample of 6,000 people single vaccinated versus 2,500 double vaccinated, we clearly showed that vaccination is protective against long COVID. And this is an important message to share with individuals, particularly in healthcare settings, where we come across a lot of individuals who are still very hesitant about having the COVID vaccine. And while many of them will now know people who have been admitted to hospital or even died of COVID, it's worth pointing out also that not only does vaccination reduce those two very important endpoints, but it reduces this nasty prolongation of symptoms that can last for many months. What are the predictors of long COVID? Well, as I've alluded to, age is a clear predictor. It's much more prevalent in females than in males, and this is in keeping with other post-viral fatiguing illnesses, which are similar, we think, in many ways to long COVID. Having a previous diagnosis of asthma is clearly a risk factor for ongoing symptoms, particularly the shortness of breath. We couldn't find evidence of a clear socioeconomic gradient, but there is a relationship with poor pre-pandemic health, so multiple organ systems involved with pre-morbid conditions is a predictor for long COVID, as is prior psychological distress. And so in summary then, age, female sex and pre-existing asthma are the medical conditions which are most predictive of long COVID, while pre-pandemic poor health status and psychological distress are also predictive of long COVID.
Thank you, Francis, for that. We are seeing, I think, a more active conversation, at least in some settings, about long COVID, and it seems that it will be one of those important discussions at this time and also in the post-COVID era. So we can come back to that in the questions, but thank you so much for that and the really interesting research insights. We'll move on now to Dr. Juan Palomino, who kind of, I think we'll use some of that presentation we have already on the unequal effects of COVID, and we'll talk about the economic effects of policies, especially how they relate to issues of poverty and inequality. Over to you, Juan. I should have said Dr. Juan Palomino, Post-Doctoral Research Officer at the Institute for New Economic Thinking, the Department of Social Policy and Intervention, University of Oxford, and also at the Complutense University in Madrid. Over to you, Juan.
Thank you, Antonis. Thank you for inviting me to speak here, and for the kind introduction as well. Let me share my screen. Let me know if that works.
Yes, that works.
Okay, so well, my brief presentation is going to be not on the health long-term outcomes or mental health, but more on the poverty implications that COVID and the closures that, of course, obviously helped to stop COVID indirectly had on poverty, how the government intervention did really cushion the potential effect that COVID restrictions and COVID itself could have had in poverty, at least in Western European countries that could afford such intervention, right? And then in the more long-term effects, that has left the public finances impacted by that. So I'm gonna explore a little bit what are the options to rebuild the public finances and finance this. And then in the second part of this brief presentation, I will talk more about the impact that school closures have had on education outcomes and the long-term implications of that and how that may affect inequality as well. So the good news is that we, compared to the estimations that we had at the beginning of the pandemic of how much poverty could increase due to the implications that COVID had on the labor market, which, for example, with colleagues here, we predicted that on average in Europe, the rate of people that was at risk of poverty could increase up to 9 percentage points. Some other works estimated 6 percentage points, and accounting for policy that could go down to 2 percentage points. But now we have like real data on how much poverty went up after the government intervention. And the good news is that even though this is very unequal among countries and among social groups, on average, the effect of an increase of 1 point in the rate of people at risk of poverty is much less than what could have been in absence of government intervention. So that is, at least in this crisis, in the economic department in Europe, governments did more than they had done before. Of course, this has had an effect on public deficit and on government debt, because at the same time that some expenditures were taking place, like the furlough schemes to keep people in their jobs, revenue went down. So the average increase in public deficit was from, in 2019, it was just 0.5% of GDP. And then in 2020, it went up to 7%. That meant that public debt, of course, government financed this in the first instance with debt. We had the Euro bonds in Europe, which was also a good thing. And public debt went up from 77% in 2019 to 90% on average in the EU countries in 2020. Of course, that leaves us the question of how to finance this. This is an increase of 10 points in GDP, in terms of GDP, in debt that will have to be repaid in the future. And then there's been proposals of new taxes that could be at the same time both equitable, fair, and provide the revenue that's necessary to finance these interventions. There's been the new corporate tax, which is, in my opinion, it's a very good thing, having a minimum effective tax rate for big corporations. However, some organizations like Oxfam and the European Network for Debt and Development think it's not enough. There's many loopholes in the small print of that, like exemptions depending on the number of employees and also productive assets. So it's mostly targeted to digital companies, and it probably shouldn't be like that. then there's also new taxes that can achieve both the green transition that we need now more than ever, and at the same time generate revenue for that. But I want to focus on a temporary wealth tax proposal that's been put out by Lande, Seith, and Shullman. And this is, of course, this is not being considered yet, but I wanted to point out what are the advantages that this type of temporary wealth tax would have. It would affect only the top 1% of the population in Europe. It would be progressive, so 1% for all the wealth above 2 million euros, 2% for the wealth above 8 million, and 3% for the billionaires. And this is predicted to raise in a 10 years span only all the extra debt that has been generated by COVID. And the good thing is that it affects only the people at the very top. It doesn't affect the wealth of the bottom 99%. And we know that this top 1% was the share of the population that was least affected by COVID restrictions. Most of these companies or people with very high income and wealth kept their jobs. They had the capacity to telework, and at the same time they decreased revenue and because, well, traveling, for example, was not permitted. Many luxury expenses were not happening. So saving and wealth for this small group went up. So it in a way it can be fair to address this group to kind of contribute fairly to repay this government expenditure, and it would not harm growth, because it's not a tax on current investment. It's just on the wealth that's been accumulated. It's temporary. So I think it's something that should be considered, and that is not in the public debate as much as it should. Let me now move because I wanted also to kind of blend with the overall sociological approach of the panel. So I've been compiling a little bit of the evidence that we have, and this is different from poverty and inequality in the strict economic sense. But of course, learning, we know it gives people the ability to go up in society, to have future earnings. So so the impact that COVID has had on learning is relevant not only now, but also for the future development of inequalities. So we know that school closures tended to be greater for ethnic minorities. Not in some countries it was central determine how much schools closed, but in others like the US or in some areas or in the UK, it was up to the district level. And in those cases, we saw that it was related, it was correlated negatively with income. So people in more deprived areas were more likely to suffer school closures. We know on average that test scores went down. There's been studies comparing the first pandemic year with the previous year, and that it's clear that it had an effect on how much students learned, and that effect was greater for students from more disadvantaged backgrounds. Of course, it's we know that those parents probably have less ability to dedicate time to the kids, to compensate the absence of in-person teaching, right? So that's also increasing inequalities, and it's also related to probably long-term psychological. We don't know how long-term they will be, but what is being shown is that students tend to answer that they didn't like school more often as the pandemic went on. So it's been also discouraging in terms of motivation. So online learning, of course, could compensate a bit the absence of in-person learning, but in this respect, it increased inequalities because online learning is relatively productive for students from high income backgrounds. And it's been shown with data from Germany that the students from low income parents tend to spend a greater share of this new time at home that they had, not doing homework, but on video games and not learning activities. And it's also been shown and this does not only refer to compulsory education, but also to people to lifelong learning process, that in high income areas, online searches for online learning were much higher than in more deprived areas. Of course, it's pretty obvious that not everyone can go to Coursera or edX if you don't have a previous background and also, of course, the online access. So also in terms of how much time was spent doing homework. So in the UK, it's been shown that children of families at the bottom of the distribution, the 10th percentile, spend 35 minutes less per day on homework during the pandemic than those at the median, and 1 hour and 10 minutes less than students whose parents were at the 19th percentile of the income distribution. So online learning might cushion the effect of not attending a school, but on the other hand, it may increase the inequality that's associated with the socioeconomic status of students. And finally, and this is my last slide, there's been some studies that have modeled based on previous data of how education impacts long-term income later in adulthood, and a one-year school closure can be translated into a 2.1% decrease in earnings over the lifetime, and 1.2% in welfare if welfare is measured as lifetime consumption. Of course, these are projections. We don't know how well schools could compensate that in the incoming years, whether this effect would be a scar not only in our health and our mental health, but also in the ability of the most disadvantaged students to move up in society later on. And that remains to be seen. But of course, that I think looking long term, it should be something that governments should take into account and have a long-term vision in terms of how education can compensate for this 1 or 2 years that we've had of school closure, or at least handicap learning for many students. Thank you.
Thank you so much, Juan, and a really interesting presentation on the broader social context and kind of how it applies to help us understand more some of the health impacts that we are discussing as well. So thank you for that. We'll move on now to Dr. Magda Osman. Magda is Head of Research at the Center for Science and Policy, University of Cambridge. And sticking with that theme of, I think, the social context and those impacts, Magda will talk to us about not just the COVID pandemic, but the COVID infodemic and the role of misinformation in the past couple of years. So over to you,
Magda. So hopefully you can see that.
Yes, we can.
Okay, good. So yes, as Antonia said, one of the other problems that resulted from COVID is the wealth of information, and in association with that, the wealth of misinformation. So kind of thinking ahead, so the kind of structure, this is a very brief presentation with kind of very top line kind of arguments. is thinking ahead. So in terms of, if this is a real serious problem, then we need to understand it in order to figure out how to address it and try to determine the scale of the problem. So yeah, there's lots of discussions around how serious the problem is, which resulted in the World Health Organization considering the problem of misinformation as an actual infodemic. So this led to us in the lab doing some actually very basic research. So just to start things off, so while there's lots of discussion around how to characterize misinformation in the academic literature, and not everyone agrees typically, there is some basic kind of consensus around the fact that misinformation generally implies information that's misleading. So, but that can happen inadvertently. So disinformation by contrast is information that is deliberately designed to mislead. So, while at the academic or kind of expert level, we might have an idea of what those kinds of things mean and draw kind of distinctions, then what is it that the public actually take this term to mean? So we asked a number of questions, not just what people take it to mean, you know, what information they use to judge whether something is misinformation or not. The general findings are, so we sampled participants from a number of different countries, and the public conceptualization of misinformation is that it's information that is designed to deliberately mislead, right? So intentionality matters here. So that is that the public take misinformation to align more closely with what academics consider as disinformation, right? So that's interesting, because if we want to start targeting it, then we need to have a better idea of what actually people take these things to mean. And not only that, also the things that they use to identify and judge what makes something misinformation. So, and another motivation of ours is, well, if we need to address the problem head on, then we need to understand also what insights we can gather from different disciplines. And so there's a vast amount of work that's been done, and it's accumulated over many years. So this isn't new, it's just that it's kind of mushroomed, it's kind of blossomed as a result of the pandemic. So there's been enormous kind of appetite to explore misinformation, understand it, understand the effects of it and the causes of it and so on. But there's no unanimity across disciplines. So if you look at, so we probed into this. So we looked at history, philosophy, historical epistemology, psychology, sociology, and so on. So there's a kind of list here, and tried to map out just generally where they fit in terms of two dimensions. So one is the extent to which the problem of misinformation is perceived as urgent to minor, and whether it's seen as new or old, because all of those things matter in terms of how one considers targeting the problem. So they don't all map in the same way on these different dimensions. So, I mean, partly because they don't all agree, we don't all agree from different disciplines what the term means. But once you kind of get past that, the effects of misinformation are characterized differently by different disciplines. So the way law considers the effects of misinformation is very different from psychology, is different from journalism, studies, and history, and so on. Where you do see some kind of convergence, a general sort of agreement across disciplines, is that and by association, the degree of urgency of the problem. So for disciplines who think that, or treat misinformation to be a significant problem, like an urgent problem that needs addressing now, to stem kind of future problems in the future, is that technological advances mean that the access to misinformation is greater, so the speed, access and spread is much greater than ever before, which is why it's considered to be an urgent problem. So here's some caveats before I end. And it kind of gives you a sense of what issues we face if we're going to try to target misinformation as a problem. And that's to start with, is to identify the scale of the problem and where it might be more significant and less significant, because it allows you to prioritize the interventions that are needed and to make sure that the interventions are proportionate to the actual problem itself. So just a few things to pick out before I finish. So this is not just our work, there's some recent work looking at this. Some of it is informed by work examining COVID misinformation, but also misinformation in other kind of domains and territories, including climate change and so on. So if you just try to gauge the scale of the problem of misinformation by, let's say, the amount of untrustworthy websites, assuming that untrustworthy websites distribute greater misinformation, whereas trustworthy websites distribute accurate information, then you can see that actually proportionally there are considerably fewer untrustworthy websites. You think, well, that's a good thing relative to the trustworthy ones by a factor of an enormous amount, so 30 million to 2 billion. So survey work looking at the nature of the communication on social media, because that seems to be a territory where people are particularly concerned about. Exchanges of misinformation suggest that actually the function of social media isn't for social, well, mostly to discuss social issues than it is political issues. Two other things which I'll pick out and then I'll stop is that the reason when you look at where people encounter misinformation when they distribute it, the reasons for why they distribute it isn't only to misinform other people. There are many other reasons people distribute misinformation, partly to highlight that it is misinformation, or for amusement purposes. So you think not all reasons for distributing it are the same. So that's one issue that we need to also consider, the motivation behind sharing it. And then the other is, and it's a more profound problem, and it's a problem that we see that's a perennial problem for psychology, is to be able to show that a piece of information, the assumption is misinformation is a significant problem because it has direct effects on behavior. But actually, empirically, that's incredibly difficult to demonstrate. So you have to assume that information impacts people's beliefs or attitudes, which in turn affects their behavior, right? So to be able to trace that is actually very difficult. It's difficult to do in psychology anyway. So we have to evidence it more in order to try to direct our efforts in successful ways to be able to reduce any significant impact of it. But that requires ramping up the robust efforts methodologically to demonstrate that problem. And I'll stop there.
Thank you for this, Magda. It has been one of the buzzwords of the pandemic, misinformation and the infodemic, but thanks for crucially explaining why this is probably a lot more complex than people think. So we can come back to that in the questions. The last talk for this session before we cover some questions, Dr. Sandra Shullman, 2020 president of the American Psychological Association and now managing partner, the Columbus office of the Executive Development Group. Sandra is going to talk to us about the human experience in the post-COVID world. Over to you, Sandra.
Thank you very much. Let me put my Let's see if that solves my problem here. Let's see. Let me see if it'll move first before I do anything. Nothing is moving. Okay. Let me stop the share a second and try that one more time. Let's try this. Okay, much better. Thank you.
Perfect.
Thank you very much. I'm very honored to have been asked to be a part of this. And I should add that I do teach at HEC in Paris as part of their business school program. So I spend a good portion of my life while being an American in various parts of the world, especially in Europe. Today, what I want to do is focus briefly on issues and approaches by psychology and psychologists that will carry forward through COVID and its aftermath. These issues and approaches apply more broadly to future global crises and challenges, not just to COVID per se. The COVID, as we know, as we've experienced this pandemic, it has highlighted increased uncertainty, as several people have mentioned earlier. And uncertainty being now the more normal human experience. And most important here, I think, is how psychological science informs us about the impact of prolonged uncertainty experiences in every sphere of life. And when you see some of the data that my colleagues have presented here, we're talking about from health to education, to work areas, to legal policy and government systems. How people conduct themselves under heightened levels of uncertainty is very significant. I myself conduct psychological research about effective leadership under uncertain conditions and have personally seen how COVID's prompted a heightened need for psychological science to address a wide array of questions for leaders and for citizens about how to live with chronic uncertainty. And the notions about living under chronic uncertainty have direct relationships to the levels of anxiety, depression, and other conditions that we're seeing in virtually every context that citizens exist in. So one of the things that I would say here is what psychological science can offer in the wake and the aftermath of COVID-19. We have, as you can see through some of the data that's already been presented, relevant information to provide and inform governments about prevention, intervention, and treatment associated with a variety of crises, especially if we espouse a global population health strategy and a global population mental health set of approaches. This means that we should be, as social and behavioral scientists and psychologists, advising global organizations on the importance of community approaches to mental health, for example. And beyond that, psychologists and psychology can apply the science of human decision-making to all serious conditions that involve either decision-making and behavioral change for both leaders and for citizens alike. And I think one of the things that we've learned, or our cultures collectively have learned through COVID, is that crisis is about behavior and how we respond in those situations. We now, so in the post-COVID context, what does psychological science really offer? Some examples here. We now know more and have better organized knowledge around some very key challenges, including anxiety and the spread of misinformation and how they interact with one another. And I think Magda's already begun to address some of those issues. We also have greater evidentiary insight into tools which can help people navigate change and manage stress at multiple levels of intervention. We also have a clearer focus on how best to advocate and address strategies for a wide range of vulnerable populations. For example, the lingering psychological impact on children. And I think Juan has demonstrated some of those issues around poverty and education. and certainly addressing issues, what we would call the social determinants of behavior, and how they affect people's livelihoods and their well-being. So what specifically has the American Psychological Association been doing, for example, that we've been focusing on that will carry forth through COVID and on into our future? We now have a lot more knowledge about strategies around vaccine hesitancy and how that relates to the spread of inaccurate information. And so that's a whole series of things that can be applied to other crisis situations and to other issues. And that includes things then about how we would communicate as leaders, for example, to communities, differentially to different populations and communities, effective messages that would help address the hesitancy issue. We also have amassed some knowledge and resources that help with the prevention of burnout, not just for first responders, although that's I think a primary issue, but for everybody that's had to risk well-being or put extra effort into adjusting to the COVID crisis. We've also been invested quite a bit in identifying and reaching out to address the needs of healthcare providers who are now in second and going into third years of continuous crisis work in healthcare around COVID. And we've also created some evidence-based resources to meet the unique needs of children and other historically underserved vulnerable populations, especially around access to care and quality care, which are limited by institutional and systemic barriers. In other words, again, the social determinants of behavior, you know, the very simple types of factors of looking at why, for example, in the United States, a significant predictor of access to care and quality of care is your postal zip code. And that's probably one of the greater predictors of where you will fare in a COVID crisis and other crises beyond that. But beyond mental health, and I think this is what's really important, psychology and psychologists have generated a lot of new knowledge and strategies to address other issues, like the new ways of working. For example, understanding the differences between what people now call hybrid workplaces and what people prefer about those versus what people might be really saying is flexible workplaces, where we have a better understanding of what individuals need to do their best work and to balance their work and family and other life obligations. There's a big difference between hybrid and flexibility. And so the research that's being generated has really been helpful in that. We also have been contributing much to identifying and addressing long-term psychological impact of COVID. And I think one of my colleagues, again, has talked some about this. But the long-term effects of COVID, there are individual effects. There are also family effects, group effects, organizational effects, and community effects of long-term COVID that we really need to parse out and understand better. And we've also been working to identify some evidence-based strategies to address the increased violence and harassment that we're seeing impacting specific groups, and again, specifically vulnerable populations, which are really critical. Perhaps most relevant to this current discussion, and coming in as a visitor from across the pond, APA partnered with psychology organizations across the globe for the last 2.5 years to collaboratively create a global psychology response. We were already beginning this work as a global community in late 2019 around climate change, but COVID brought the onset of the formation of what we call the Global Psychology Alliance, which is an organization comprised of over 70 national, regional, and international psychology associations. And during COVID-19, the leaders of these groups met twice a week. And I would point out here that one of the unintended positive consequences of the COVID response is that we brought countries together. We were able, because we could only meet virtually, that both the countries that were resourced and the countries that weren't resourced from a psychological perspective could come together because we were doing all of this work virtually. So we had countries engaged in this work that would not be coming to international conferences, that would not be coming to international meetings because of lack of resources. So we really formed a global psychology community. And this community created and translated in materials that were population appropriate in over 20 different languages that were distributed worldwide and vetted for context and population appropriateness. And they dealt with things like heightened stress and anxiety, which we all know quadrupled during this period of time, at least in the US, strategies for helping first responders, and addressing violence for specific populations, whether it be domestic violence or other forms of violence and human trafficking, things like that. The other thing that the American Psychological Association did is partnered with World Health Organization on a project that was dealing with the psychological science between COVID-19 and how people made decisions and behaved because of the COVID situation. And we worked specifically with the World Health Organization around decisions that adolescent boys made about their behavior with regard to COVID. We also partnered with the UN to address issues of health equity, mental health, and well-being. And I really want to emphasize this because I think one of the aftermaths, a positive aftermath, if we will keep this going because of COVID, is really getting much more of a disciplinary and professional global response that can help with mutual learnings that have taken place about different approaches and strategies to do things based on social and behavioral science and research. So for my perspective, like all core sciences, psychological science is able to critically inform on ongoing and new challenges. But here's what happens. This is what I really want to leave the group with. I think psychology, and I think this applies to other social and behavioral science as well, but since I'm from the American Psychological Association, I'll stick with psychology. Psychology and psychologists can be a significant partner across all nations to help address future and ongoing mental health challenges, especially if we can adopt a global mental health and population health approach, and a global health approach in general, population health approach in general. We also have much to offer about behavior in broader contexts beyond mental health. And that, I think, has been very underutilized around specific context and specific conditions, especially in situations that are marked by ongoing heightened levels of uncertainty, chaotic conditions, and crisis communication needs. We can also partner to bring enhanced understanding and approaches to crisis situations and their aftermaths. We have a lot to bring to that. In essence, what I'm trying to say here is that I believe that psychology and psychologists have been historically underutilized globally. And I'm not putting any response. I think there's a lot of responsibility to go around. We haven't taken the opportunity and we haven't had the opportunity. So we have been underutilized globally. We have core knowledge and strategies to offer. And I think one of the things that I would hope for in the future is that we would be active partners in the beginnings of, in the prevention of, and in the actual ongoing crises, that we would work with governments and organizations and policymakers earlier in processes to address these global challenges that we know are coming now and that will be coming in the future. So I hope that one of the positive outcomes out of COVID is the understanding of the impact of behavior on all crises and the impact of crises on all behavior, and that the discipline of psychology and the profession of psychology globally, all of my colleagues globally, have a lot to offer that we haven't had the opportunity to offer thus far. So I'll stop with that. Thank you very much.
Thank you so much, Sandra. That makes a lot of sense to me as an approach, and certainly something that we'll need to consider in terms of taking some learning from COVID moving forward. If you don't mind stopping sharing, Sandra, and if there are any questions from the audience, I'm happy to share them from the Q&A. But why don't I start maybe with some questions for each of our panelists, and thank you again all for sharing your insights. Elke, if I start with you, I think you pointed out, and I really agree that this has been the first pandemic when we've had some mental health conversations. You know, we've seen it's certainly been a big change compared to our experience from history. I'm wondering, and I think you alluded to that, do you think that over the course of the pandemic, these conversations have maybe missed the mark a little bit? Have they lost their nuance a little bit? You know, I think increasingly I've seen mental health to some extent even being weaponized against taking protective measures, you know, so we should not wear masks because it's not good for our mental health and things like that. So do you think that these conversations have remained useful, or do you think that we need to do something different, and as a community as well, kind of in social sciences, in medical sciences, to perhaps add that nuance back into these discussions? Thank you.
Yeah, very good question indeed, because I think there are two answers to that question. Of course, as a clinical psychologist myself and practicing in the field, I can not emphasize the importance of talking about mental health more. So I think we welcome the fact that there is talked about mental health, whatever the leverage that it's used for. It always has a cumulative effect on normalizing the fact to speak up, which is still of increasingly importance if we want to early intervene, especially in vulnerable groups like adolescents, youngsters, very well addressed by two of the colleagues here present. On the other hand, I do believe, and therefore I warmly welcome, of course, the Global Psychological Alliance. I do believe that we as psychologists and in a whole the psychosocial professionals, we lack a bit of sexiness. We are indeed today not as attractive, and I think we need to step up to the game, to lobby better, to use our words better, because we tend to nuance a bit too much, where psychology becomes a container. And I think the summary that my colleague Sandra just shared, I think that really nailed it. I think mental health is the beginning of everything. And I do applaud that in Belgium, where we will immediately activate it together with the medical professions. But then you see that it remains a luxurious thing for when they have 5 minutes to spare. And I think there we have a job to do. We have to still emphasize even further how important mental health is and increase our knowledge. And of course, that is immediately linked to the underfinancing that mental health still has across the globe, still now. And so, but I think we need to step up to the game when it comes to making ourselves heard, becoming a frequent person also in the media, in the social media. I think we are on that regard a bit too modest. And I think we can learn a lot of the research of Magda, for instance, on how to make good use of social media leverages to get our message across, because indeed there are a lot of reliable information resources also in mental health, and we did some extraordinary work. If you look at what psychologists and other psychosocial professionals did, it's extraordinary, mostly voluntary work, to also emphasize that, but it does not come across to the right groups immediately. And I think that is a challenge for us as professionals. And I think maybe APA and other, or the Global Psychology Alliance can make really, a priority of that. Because I think if we are able to tackle that, people hear us. They've seen it, they felt it, everyone. The past 2 years, everyone has felt at some point how influential mental health can be for your daily functioning, the functioning of your children, but also the functioning of society. So yeah, we can step up to the game, but we have some work to do.
Thank you for that, Elke. That resonates a lot. Certainly I have colleagues in public health who have been saying that in some cases, it's not that we need better evidence, we need better arguments, we need kind of better articulated arguments that speak to people and find people where they are, you know, in many ways. So thank you for that.
If I could add something
yes,
here,
of course.
I agree with Elke wholeheartedly, and I also think that what happened in COVID that is different, that could be a leverage point here, is that people who typically think mental health issues are for somebody else realize that it came into their homes. So these were people that were well-resourced, as well as people that weren't well-resourced. And I think that is the change. I know in the US, for example, we partnered, we didn't try directly to try to create the messages as psychologists. We partnered with our National Manufacturers Association. We partnered with our parent-teacher organizations. We partnered with the National Farmers Organization. And these were organizations that came to us and said, we would like to have you in partnership because we have people that have never talked about mental health before or experienced it as something that's now part and parcel of their daily lives. And shame on us if we miss the opportunity that is provided here to make this a normal part of how we consider public policy for the public good and getting us involved. And you're right, Elke, I would agree wholeheartedly. It is not just that we're not invited. We haven't been, sexy is as good a term as I can think of as well, to be in there. And that's part of the strategy. I know at the American Psychological Association, we've worked very hard now on training leaders, training advocates, getting psychology out from under the privacy notion and putting it in and saying, we're here for the public good. We're here for public impact. We're here to help the public. And so I think we also have a generation of psychologists coming through that see their roles to be more public advocates and not just to be individual treatment providers. And I think that will help tremendously.
Thank you, Sandy. I think this applies to other disciplines within kind of the broader health sector as well. We see in my sector, public health, we see more people interested in public mental health. But also we see, I think, healthcare practitioners, people who work on frontline services, kind of really now thinking, how can I influence, you know, the systems? How can I look at patients holistically and the context that people have kind of when they come to me. So thank you for that. That's sounds great, really useful. Magda, if I come on to you, and what's your view on that missing sexiness? Maybe is this part of the problem when you think about misinformation and the role of us as professionals? So what do you think are the barriers for in research, maybe in better understanding how big a problem it is? Because you did really well, I think, outline the complexity of the issue.
Well, I would say that psychology is probably the one area that's gained quite a lot of kudos and attention in this domain. So I agree with Sandra and Elke. I think also because of some of the policy work that I do, that psychology seems to is tacked on at the end. So you have other more legitimate sciences kind of being invited at the table early on, and those who are technically more advanced in terms of kind of statistical nuancing and modeling and so on. So the economists are brought to the table, and then and then psychology. So there needs to be some kind of revision around that. Because once you're looking at kind of social, individual kind of or macro level issues, they're invariably involving people. But I would say actually misinformation is the one area where psychology really has, and in some cases to detriment, right? So I would say that sometimes we're jumping the gun in terms of thinking about what impact that might have without being that careful. So there's we don't want to feed the assumptions without being sure about what we can say precisely and where the effects of misinformation on behavior are. Right, so because you can't then introduce effective interventions, and that has a backfiring effect on the community. Right, so if we're invited to the table to introduce interventions to stem the effects of misinformation, and we aren't characterizing the issue effectively through robust methodologies, if then they don't work, then then we lose credibility. So that has knock-on effects. So there's a reason for drawing attention to using also the insights from many other disciplines to work collaboratively. So I would extend out what Sandra's saying to, while we can establish effective collaborations globally because of the community and the type of community we are, there's also a need to actually extend that beyond to include other disciplines that we don't typically work with, which we should, right? Because the better we are at doing that, the more effective we're going to be in kind of introducing policies that will work, or understanding why they don't work better. So sorry, that's quite I drifted off, but hopefully that answers the question.
Can I pick up on something that you said there? So just to return to my work previously on low back pain, this is a massive social problem that just gets worse and worse as the years go by. And we've known for a long time that the biopsychosocial model best explains it. And my work using, as you referred to, Magda, sort of harder science and modeling, has shown using genetics that actually genetic factors underlie all three elements of that biopsycho and socio model. So that's very robust evidence that the model is real and effective and does very well explain low back pain. But the problem we have is that despite increasing numbers of clinical trials, for example, very high level evidence showing that many orthopedic procedures that are done for, say, shoulder operations or knee operations are no better than placebo, our politicians or our healthcare services or our rationing around health still favours sexy things like surgery and not the unsexy psychological. And so how do we raise the profile of psychological therapies and obtain the funding that is so required? And this was clearly a problem way before the pandemic, the underfunding of psychological support compared to the willingness that society seems to have to throw money at surgical procedures and things with needles and gadgetry, which, in many instances or increasing instances are shown really not to be of any benefit over and above placebo. So I guess my other point I wanted to make was whether we should really use COVID as a springboard to boost psychological therapies, or whether in fact everybody's rather tired of COVID and we should return to the pre-pandemic. This is the evidence of benefit for mental health and psychological services. We need more money moved from things that don't work, that have been shown not to work, and placed in areas where they do work, even if they're not sexy.
Thank you for that. Francis, I will come on to people who've raised their hands. And I think psychological support for me maybe sometimes is missing within those community contexts, and not just within kind of our health and care services for people with issues like chronic pain, maybe long COVID, as we mentioned as well, and issues like that. So thank you for raising that. Elke, so your hand going up first.
Yes, thank you. I think Francis' extremely valid point, of course. It's not just for chronic back pain, it's also for other things. It's human, it's a part of human nature where we really want to feel that we are taking action. And we still have that stigma on psychology. It's not actionable. So I really love what Antoni said, where we don't need better science or better evidence, we need better arguments. And we need actually to take from our science and evidence actionable insights. We see that also, for instance, discussions on how to treat perfectionism, where you have the option between a simple intervention, where the psychologist is merely a facilitator, or, for instance, EMDR, where there are a lot of actions and bilateral stimulation going on. Well, psychologists really have that bias, saying, well, perfectionism, we can treat it best with EMDR, while science says, no, that COMET treatment option is better. So it's in human nature. And also there, I think we need to address also these issues that have, from where I stand, really been crystallized by the COVID experience. And we should not neglect them. For instance, also that guru-like thing of medical science. We are now harvesting the results of the things we've spread ourselves. That's the idea, that medical science will be able to solve everything. And so everybody else is also expecting doctors to take concrete action to solve the things. And of course, when we talk about chronic medical conditions like chronic back pain, or we talk about mental health, that's a major issue, because there, I think we need to focus more on the process and to target the vulnerable groups. And I think there, just moving back to pre-pandemic, I feel you. I think it's important to not neglect what was already emphasized, of course, but I think we need to take those new insights with us and emphasize the importance of community, because also there, Jose targeted the vulnerable groups. And what you see is when we want to help them, that our vulnerable groups, the non-weird individuals, they will look for help in their community, not through individual or individualized psychological therapies, whether it's e-health or face-to-face. And so we need that community-based psychology as well, and move that forward, and maybe combine that, because otherwise I think the major part of society that is now worsened through the pandemic will be left behind, and that will have, I think, a huge economical burden in the years to come otherwise. So I think also there it's going to be end-end. And so again, a call for action from my end to whomever has a decisional power to invest more in mental health, even today, to address those both issues. So those were my 2 cents I wanted to add.
Thank you, Elke. And I think I agree, there is an opportunity with COVID. We've seen the worst of inequality, but we've also seen the best of community grassroots action. So probably lots to build on from that. Magda, then I'll come on to you, Sandy.
Yeah, I'll try to be brief. So Francis, yes, I am sympathetic. I think, although I will say that I think for certain areas, they're in and of themselves, they're not seen as particularly, let's say, sexy. So lower back pain is not seen as, terribly interesting compared with other things. So that in and of itself is an issue. Right? So pairing up with, multiple disciplines, including psychologists, let's say, that there is appetite for that, and COVID has prompted that, but here's a kind of cautionary note. So I think actually the UKRI, so the UK's kind of research funding is supportive of this kind of collaborative, kind of interdisciplinary work. Often that's couched in the frame of using behavioral change in combination with other disciplines. That can be good, but the cautionary note is that how behavioral change has been used, and also in the context of COVID, has been highly politicized. So how one aligns or allies with particular kinds of methodologies from psychology one has to be quite careful of, and also who, right? So, there's some people who already work, in multidisciplinary kind of context with, medical profession, or, with economists and so on, machine learning, and, all of that kind of, so it goes on, but it goes on kind of under the radar. So, it is possible. It's just finding the right people to work with, and also how that's framed. So it's not framed in a way that kind of backfires.
Thank you for that, Magda. That makes a lot of sense. Sandy, I'll come on to you. A reminder to our live attendees, you can ask your questions using the Q&A function, and we will address them. Sandy.
No, I actually agree with my colleagues wholeheartedly. This is going to sound like a pie in the sky statement, but what we're really talking about here is, should we go back where we were sort of and keep trying to advocate for certain aspects of mental health? Or should we use the opportunity, I say that with due caution, the opportunities that are provided in a COVID-like environment to really create global, multidisciplinary and multiple level intervention strategies coming from the social and behavioral sciences. I'm reminded, for example, that a related concept to the work that you do, Magda, comes out of psychologists working in economics, people like Daniel Kahneman and his colleagues, talking about what makes people act against their best interests, even though they consciously might know that that's true, they still act against their best interest. That's different, but related in some ways to some of the issues around misinformation. I think the other thing we need to remember is that disciplines like psychology are actually absorbed by many other disciplines. A lot of our protocols and things like that are out in other sciences, and they're out in the business world. And I think the partnerships we create with those organizations, when we go out and actually work more visibly with them, makes it clearer that we are making those contributions, and it makes it more central, sexy, central, whatever you want to say, to the discourse. The other thing I want to raise again that I mentioned before, and I think is important, is taking a population health approach, a global population health approach, a mental health approach, which says we're going to do multiple levels of intervention. To me, is absolutely critical to supplying the care that is missing, but also to getting at the levels that are needed for different groups of people in different situations. And that I think a lot of our mental health strategies have been very individually focused. And that's one piece of an important part of it, but it's by no means the whole piece. And I think some of our disciplines, I think psychology in particular, has been slower to come to the more multiple level intervention approaches, the systemic and structural approaches, than we needed to be. And that's, I think, where we need to add those other components now, which is why, rather than splitting off mental health providers from psychology that works in other contexts, is a mistake, because we really need to recognize those organizational and systemic issues are what create the social determinants of behavior, that create the conditions under which people behave. And those things have to be looked at. So I'm hoping that we can, with the use of technology, larger database analysis capabilities, that we can start to integrate some of the data from these disciplines and across these contexts to get at some, I think, important larger analyses of the factors that really affect our daily lives and make us more relevant.
Yeah, thank you. Thank you for this, Sandra. That's a very meaningful, I think, call to action. That makes a lot of sense to me. Francis, if we stay on this topic, maybe of that connection of mental and physical health and the social context for a moment, and I think, thank you for raising the issue of long COVID. I think that it will be an issue that will be taught in medical schools and public health schools in the future, especially how it emerged, how it became a diagnosis, the whole issue of patient activism that kind of really fueled awareness around it. Do you think...
Can I just interrupt you there and say, I hope it's not just taught as long COVID, because we've known for many, many years that there is a post-viral syndrome. There are fatiguing illnesses that follow many, many conditions such as autoimmune arthritides, chemotherapy, radiotherapy, all these cause people to feel fatigued and unwell in ways we don't really fully understand. And actually, I would be very anti hiving off the COVID and making it the special case and saying, we now have to do better to understand all these conditions across the board.
Yeah. Well, I think you started to answer part of my question. The first one was, from your experience, how is this similar or different maybe to other prior illnesses? So if you want to build further on that'd be great. And also, do you see it, are you optimistic that it will remain and become hopefully a bigger part of the conversation when it comes to protective measures or support that is available for people? What's your sense? Are you optimistic or not so much?
So I think there are two parts to the response for that. There are clearly some organ-specific type of symptoms, the shortness of breath, the relationship with asthma, the neurological, the cardiac symptoms that people have long term. And it's very important that we support those, of course, in an organ-specific way. I suspect there won't be specific treatment for that. It's a lot of the management is around explaining to people that these are normal symptoms. They're most likely to settle with time, to try and, remove the anxiety that symptoms provoke in people when they've been going on for a long time. I think to respond to the comments around fatiguing illnesses, and that's clearly a very major part of the long COVID syndrome that is experienced by a significant proportion of those who are infected with the virus. We've known from other post-viral type fatiguing illnesses that they are linked to inflammatory cytokines, so the chemical messengers in the body that control inflammation. We've done some work on Twins UK looking at inflammatory cytokines that were collected before the pandemic. So it was very useful to have a longitudinal study. We could look at people and ask the question, are they more inflamed inside before the virus strikes? And what we actually found was that we did find elevated levels of a particularly inflammatory cytokine before the pandemic in people who had fatigue from any cause, but it wasn't specific to COVID-19 long COVID fatigue. So in a way, this is helping us build up a picture and a better understanding of the mechanisms in chronic fatigue, but we couldn't see anything that was making COVID fatigue different from any other general fatigue. And so that's one benefit, if you like, from the funding that has followed the COVID pandemic. We will hopefully get a better understanding of these mechanisms across the board and be able to apply them to all the conditions across the board.
Thank you for this, and thanks for sharing those insights. Lots of really valuable evidence, it seems, for people to catch up on, I think, as well. Thank you. Juan, if I come on to you and maybe think about the bigger picture of policy impact, and by the way, this is probably the last call for questions from live attendees. So thinking about those broader policy changes, you gave some really good evidence on what has worked, what hasn't, and what could work. I'm interested in the conversation about the wealth tax. I think we've seen it really becoming a point of activism. We've seen it becoming part of the mainstream, I think, pre-election conversation in the US and elsewhere. Do you think the evidence you shared was compelling? It did make a lot of sense to me from a macroeconomic perspective. Do you think it is realistic kind of to aim for something like that? And are you optimistic that there are other potential kind of large-scale policy measures like this that could help us essentially weather the storm over the next 5 to 10 years?
Oh, thank you, Antonio. It's a very good question. If I'm honest, I'm not very optimistic that such suggestions will be implemented in the short term, especially now with the unfortunate new energy crisis and the war in Ukraine. That it's perhaps not the best time now to raise any taxes for the moment. So these may have postponed the debate about rebalancing public finances a little bit, but it will have to be done, right? We can we now probably would be counter-cyclical to go the path of raising taxes, even for the very rich, because which is probably, and that's one of the strong points of a wealth tax, only for the very wealthy, that it's less distortionary than a general income tax that can deter effort or productivity. But of course, it's hard. The thing with a wealth tax is that at least part of the wealth governments fear that if they are the first to go that path, people can move their assets, companies can go offshore. So I think the European Union, it's a very good framework, and it worked with the OECD for the corporate tax, not for a personal wealth tax. But I do think it's something that has to be decided at a supranational level, at least EU level. But I mean, at the same time that I'm not very confident that this can be done in the short term, I think in the medium term, we are realizing that wealth inequality is much higher than income inequality. There's a lot of people who have no wealth at all. There's more than 50% of the population don't own anything. They may have a car, but nothing really significant. And there is no easy way to counteract that. And if at the same time that we can balance that, we can obtain funds for these new welfare state needs that COVID and post-COVID have, like on education, on health, on mental health, I think we sometimes forget about how do we raise that money. And there has to be a public concern and a public movement about, okay, we need to spend better, that's for sure. We need to stop like superficial spending that governments may have, but at some point we have to think, oh, we also need like to get more funding, and wealth is something that's never talked about. It is true that for some people, okay, it's like double taxation in a way. I was taxed by the income, then I transformed that income into wealth. Why should I pay now again? So that's an issue, but no one talks about that when we are taxed first, when we get our income, and when we pay VAT after when we spend it. That's also double taxation, and it's never been questioned, right? So I think at least the debate is there about getting effective and fair taxes that can help balance this government expenditure, and I'm optimistic on that it will happen, but I don't think it will happen very soon. But I think that the movement about thinking of fair ways of financing public expenditure, it's there.
Thank you for this. It understands quite a complex area, and it seems to me from what you are saying and from what our other speakers are saying as well, maybe the best asset we have at the moment is to really understand the evidence, the biopsychosocial model as well. I think everyone was an advocate of that, and the very clear evidence behind it in terms of resilience and recovery and support. And then use it in influencing change and really ensure that maybe
exactly.
we can.
And sorry, if I may, Anthony, because this can link to both information, behavior, how we approach people's, because when people know about how unequal wealth distribution is, they don't think the same way. And so it's about, and then when you want to implement a new tax, there's a whole lot of work that has to be done in the realm of public opinion and getting the right information, and of course maybe there is like good reasons not to implement it, but I think the only thing that filters sometimes is, okay, tax is bad. and I think there should be better ways of conveying that, and I think behavioral sciences and could have a role in connecting with governments in okay, what is the best way of explaining to people this and trying to change behavior, of course, tax compliance and many other realms. So it's all, everything is sort of connected in that way.
Perfect. Thank you for that. That's very helpful to make that connection. So maybe we can close with this, and maybe Sandra can get your thoughts on these. You've worked in probably the highest level, people at the highest level in the corporate world, policy, third sector. What do you think that works? And maybe that's the learning we can take, as I can see that everyone is kind of rallying behind it, the view of we need to improve our influencing. What do you think works maybe to be better influencers in using, the social sciences, psychological science, and the really good kind of evidence we have in those political circles and other kind of circles of that have real influence over people's lives?
Okay, well, I'll give it a whirl for a start here. I would say one of the things that I this is a personal belief that I have, is that we have to respect the people that we work with. And I think in academia in general at times, and I would say in psychology, I've heard a number of colleagues say things like very disrespectfully about corporations, organizational world, the rest of the political world, a reluctance to engage because it's not a pure world, and it's not a private world, etc. And so I think a first piece of building partnerships, which is the first part of what would be a strategy, is to recognize then that we go in understanding the needs of our partners and what they and translating our work into the needs of those partners. My personal work in both not-for-profit and for-profit organizations is if you are aligning what we're trying to do with the goals of those organizations and understanding how to make those linkages, they're very willing to listen. I've always taken the approach when I walk into those organizations that I understand some things about human behavior, but they are the experts on their organizations and where they're trying to go. And you make those linkages and those partnerships from a mutual collaborative perspective, not coming in as the experts to tell people what to do, but to partner with the shared expertise you have, whether that's organization to psychologist, whether it's global group to global group. It's a partnership, it's a collaboration. And when we understand that and we can get out a little bit of what the expert model is and how to translate what we do into the needs of other people, I think that's going to go a long way. I'll start with that and see where my colleagues want to take that.
Any other thoughts?
Yeah, I can corroborate that. I think partnership is the first step. Yeah, I think it's something we need, especially to learn as academics, is that the world outside our universities that we perceive as very biased and very influenced by lobbying, that's not necessarily a bad world. And I think there our value proposition that comes from a very scientific place, like Sandra already introduced, needs to be translated, and we need to also to dare to chunk it. A huge fundamental research insight can be chunked into easy, readily understandable, actionable insights. And when I look at my colleagues, I do feel that we're not well prepared to do that. Chunking a scientific insight doesn't mean that you are reducing its scientific value. It's just merely translating that. And so chunking and daring to do so and learning our peers and the next generation how they can do that in a trustworthy way, I think that would be my course of action.
Thank you. Oh, Magda.
Great. I mean, yeah, I agree with both of you. And yeah, there's kind of seems like there's nods all round. I suppose one way to kind of rephrase it also is, you know, in some way when you show humility, which is what I think you're getting at, Sandra, basically, is you ask the right questions as a result of that, right? So that, you know, there's a way of phrasing questions that you reveal your own ignorance and humility, and you reform what you think someone means by asking the question. That's a great way as an opener, because that reflects a vulnerability, and then it gives the opportunity for the expert, assuming you treat them as an expert, the outsider, to come in. So I think that those things in combination are being able to actually be incisive and asking the right question, and also revealing your vulnerability through the questions that you ask, is a great way to. I'm cautious about it being influencers. Yeah, maybe informing and advising. Always, and what influencing, yes, carries a particular loaded, especially in the social media world.
Thank you for that, Magda and Sandy.
If I could just add briefly, and perhaps this brings us full circle, is we started, and I think Elke started by talking about the uncertainty that has heightened under COVID. And what I would say is, in the research that I've been involved in for the last 20 or 25 years around leadership under uncertain conditions, what we're saying, I think, in response to your question, is that good leaders are really good learners, and they go in with a curiosity, and that's where the humility piece comes in, that you are there to learn. And I think the expert models we have created in academia make it a bit harder for that mutual learning to take place. That somehow that expectation is we will impart information rather than we will exchange and understand and collectively work problems together in real time, which is the challenge of the COVID century, which is, you know, the classic example of flying the plane while you're building it. That's what we have to learn how to do. And that's very, very hard, I think, for expertise-based careers to understand, where you take years and years to study things. We have to be more responsive to real-time situations and to mutuality and interdependence in understanding how to apply what we do know as experts to the real world situations of today. So I think that's part of what's going on as well. We have to be good learners as well as good experts.
Thank you, Sandra. Such a good way to close. So I think if we look into the past couple of years, there's really, in many ways, it's quite a grim picture of socioeconomic inequality, physical and mental health impact, misinformation, you know, these important issues you have raised. But hopefully what we have done in the past couple of hours is show maybe how we can look into this crisis from a solution-focused lens, and maybe how we can use any opportunities that came up and any issues that have come up to drive change going forward. Before I close, Elke, up to you.
Yeah, I just wanted to add, because of course, as a psychologist, these are also major intriguing times. And sometimes it feels a bit weird to say that, but I've learned much more in the past 2 years than I did in the rest of my plus 20 academic career, because we all have to understand that in new unforeseen circumstances, we immediately get a glance of the real drivers of ourselves, but also from society. And I think we have a common goal in this post or pre-post COVID era, and that is to make it better for everyone. And where we were very good at covering whatever was going on, selling things, packaging in very sexy things without actually addressing the real thing, what COVID did was to just immediately opened up everything and exposed the real drivers. And we need to take this momentum, not just in mental health, but really broad momentum to take our actionable insights and improve the rest of the world for the upcoming years. So for me, it's not all grim. It has been one hell of a ride so far, and I feel better equipped as an academic, as an expert, but also as an advisor to go into whatever's next.
Thank you, Elke. So hopefully to the live attendees and to those catching up on demand, you've enjoyed how we have learned from each other as well within that course of about 2 hours, and hopefully lots of messages for you and things to further learn and study and apply to your own work and within your communities. So all that remains is for me to thank Professor Van Hoof, Professor Williams, Dr. Palomino, Dr. Osman, Dr. Shullman. I've been Dr. Antonis Koussoulis. I'm a public health consultant and director of the Mental Health Foundation. Thank you for staying with us and enjoy the rest of the conference.